Okay, hello everyone. I am Professor Dr. Sikatananda, Professor in HOD Community Medicine, BBMCH, Bolangir, Orissa. Will be speaking on the topic epidemiological determinants, prevention, control, measures of HIV/AIDS. HIV remains a major public health issue, having claimed 40 million lives so far, with ongoing transmission in all countries globally. The estimated about 39 million people living with HIV, two-thirds of whom, that is, about 25 million, are in the WHO African region. There is no cure for HIV infection. However, with access to effective HIV prevention, diagnosis, treatment, and care, including for opportunistic infections, HIV infection has become a manageable chronic health condition, enabling people living with HIV to lead long and healthy lives. With this brief introduction, the specific learning objectives of my presentation is to determine the epidemiological determinants of HIV/AIDS, including risk factors, WHO clinical staging and diagnosis of HIV/AIDS, the different control measures, prevention strategies, and public health interventions, and the strategic plan for control of AIDS. What is actually HIV/AIDS? Now, it is an acquired immunodeficiency syndrome which comprises of a complex set of symptoms and infections resulting from damage to the human immune system caused by HIV virus, that is a lentivirus. It is a single-stranded RNA virus. There are two types of HIV, 1 and 2. The most common is HIV-1, group M and subgroup C. HIV is further classified into M, N, O and pre. Group M has subgroups A to K based on the genetic presentation. Now, let us understand the different epidemiological determinants of HIV/AIDS, including the risk factors such as unprotected sexual intercourse, needle sharing, and vertical transmission, and the various effectiveness of the primary prevention strategies such as comprehensive sex education, condom distribution, needle exchange programs in reducing HIV transmission rates. The agent factors, as you all know, is a single-stranded RNA virus belonging to family Retroviridae and genus Lentivirus. The peak age of incidence is from 18 to 49 years. However, other vulnerable situations or factors may expose the virus irrespective of age. There is no gender predilection, however, and education, socioeconomic status, marital status, and employment. Besides this, sexually active youth, that is between 15 to 24 years, are mainly involved, and also it is based on the number of sexual partners, the use of condoms. Prison inmates and other closed settings are also have a higher incidence of HIV/AIDS. The various social factors includes having high risk occupational groups like sex workers, migrants, IV drug users, and long distance truckers. HIV can be transmitted via the exchange of a variety of body fluids from people living with HIV, such as blood, breast milk, semen, and vaginal secretions. HIV can also be transmitted during pregnancy and delivery to the child. People cannot be infected through ordinary day to day contact, such as kissing, hugging, or shaking hands. The most effective mode of transmission is through sex, and the blood contact happens to be the most efficient or the most risk of exposure. Mother to child transmission and needle prick injuries are also other risk factors. What are the various other risk factors? That includes unsafe sex, having sexually transmitted diseases, needle sharing in IV drug users, and self-perceived risk of HIV infections. Even receiving unsafe injections through blood transfusion, tissue transplantation, and medical procedures that involve unsterile cutting or piercing. Now, coming to the clinical manifestations of HIV/AIDS, that includes four broad categories: initial infection with the virus and development of antibodies, then asymptomatic carrier state, AIDS related complex or ARC, and full blown AIDS. Who are the persons who are responsible? And what is the WHO classification of HIV/AIDS? Now, clinical stage 1 is the asymptomatic or the persistent generalized lymphadenopathy. Clinical stage 2, that is the moderate unexplained weight loss, that is under 10% of the presumed body weight, or recurrent respiratory tract infections like sinusitis or herpes zoster infections. Clinical stage 3 is unexplained severe weight loss over 10% of the presumed or measured body weight, or unexplained diarrhea for more than 1 month, or unexplained fever which is persistent, that is, it may be intermittent or constant for more than 1 month. And clinical stage 4 is HIV wasting syndrome, pneumocystitis, xerovicki, recurrent severe pneumonia, HIV, encephalopathy, and so on. When you're doing the diagnosis of HIV in the program, the importance is to promote HIV testing, early diagnosis, and linkages to care as strategies for prevention and control, which also includes pre exposure prophylaxis, post exposure prophylaxis, which is strengthened. The screening test includes ELISA, immunochromatography, lateral flow immunoconcentration, particle agglutination tests, and the tests which are done are ERS, ELISA, rapid test, and spot test. ERS is done in the blood donation services, in the symptomatic patients, and in the asymptomatic patients. Now, in the asymptomatic patients, it is all the three tests are done, and there is no link between the tests, and it is unlinked anonymous test which is done. In the symptomatic patients, two tests are done, and in the blood donation services, either one of the tests of the three is done. Now, the confirmatory test of choice is the Western blot, and the investigation of choice in children is usually the infants. In infants is the HIV DNA RT-PCR, and for HIV-1, qPCR is the test which is of choice. Now, the disease progression and the response to ART can be estimated by the viral load, and the P24 viral antigen test indicates the active viral replication, and the beta 2 macroglobulin test indicates rapid progression. The CD4 lymphocyte count, which is absolute, it actually is widely used in the predictor of HIV progression, and CD4 lymphocyte percentage shows the risk of opportunistic infection. Now, there are four basic approaches for the control measures. The various components of comprehensive HIV/AIDS control programs, which includes testing, treatment, care, and support services, and the importance of promoting adherence to the ART, and how to address the barriers to care and ensuring equitable access to treatment for all individuals living with HIV/AIDS. Besides this, the continuum of care includes the whole spectrum of services while addressing the prevention, testing, treatment, care, and support needs of the at-risk and the vulnerable population. Under prevention, mass education, behavioral change communication, and there is combination of different prevention programs, that is biomedical, behavioral, structural interventions, use of male and female condoms, needle syringe programs, opioid substitution therapy with buprenorphine, which is given orally. However, methadone is not given because it needs constant vision, and voluntary medical male supervision or medical circumcision, and prevention of blood-borne HIV transmission. Now, coming to the treatment, now, the goals of ARV therapy, as you know, it is a clinical goal, that is life prolongation and improvement in the quality of life. Virological goal is there, that is greatest possible reduction in the viral load. Therapeutic goal, that is rational sequencing of drugs, achieving clinical, virological, immunological, while decreasing at the same time the drug toxicity and supporting compliance, and reduction in the transmission of individuals by suppressing the viral load. Now, the adults and the adolescents, the preferred first line of drug is tenofovir and lamivudine plus dolutegravir. And in children, abacavir, lamivudine, and dolutegravir is the preferred. And neonates, zidovudine, lamivudine, and rituximab are the drugs which is given as the first line of drugs. Now, the 4-in-1 combines the protease inhibitors, lopinamide, ritonamide, with the nucleoside reverse transcriptase inhibitors, lamivudine, abacavir in the form of granule-filled capsules, and lamivudine, nepiravine, zidovudine in a fixed dose combination as an antiretroviral medication is used to treat HIV/AIDS. However, the second line antiretroviral therapy in drugs consists of two NRTIs plus ritonavir boosted protease inhibitors. Dolutegravir and ritonavir boosted dongravir are equally effective second line treatments for HIV-1. Now, the post-exposure prophylaxis as per NARCO guidelines 2021 is tenofovir, lamivudine and dolutegravir, one tablet each given during bedtime for 28 days, and the patients are advised not to take fatty meals. The prophylaxis for TB, ART along with INH is given to all people living with HIV after ruling out TB. And for the prophylaxis for pneumocystis zerovecki, cotrimazole preventive therapy is given when the CD4 count is less than 350 per millimeter cube, or HIV or AIDS stage 3 or 4, or in malaria or severe bacterial infection prone areas that can be given irrespective of the CD4 count and the staging. Now, coming to mother to child transmission, nevirapine is given 10 milligram daily for 6 weeks from right from birth as soon as possible. Zidovudine is given if the mother has taken nevirapine based ART and HIV-2 reactive. After 6 weeks of early infant diagnosis is done, HIV DNA RT-PCR is done, and the confirmatory test is done at 18 months or at 3 months after stoppage of breastfeeding. Cotrimoxazole is provided as prophylaxis to infants at 6 weeks till excluded by a negative antibody at 18 months. Pre-exposure prophylaxis, it is available in government and private sector and has been promoted to individuals who are at high risk, and it is provided under doctor's supervision. National AIDS Control Program which was begun in 1992, happens to be a vertical program. It is merged with the NHM, and total 5 phases of NSCP has occurred, and currently the 5th phase of NSCP is being implemented from 2021 to 2026. Now, when we are talking about the organizational structure of NSCP, which includes the modality of HIV treatment services, the link ART centers and the link ART plus centers exist at the sub-district level or the hospital level and the CHC. The LAC centers are for more than 100 people living with HIV over the past 5 years in the catchment area. The LAC plus scheme, on the other hand, is initiated at existing link ART centers where there is patient load of more than 70 people living with HIV. Now, the ART centers are at the medical college and the district level, where they both in the A and the B districts, and with more than 500 positives detected over the last 5 years in the catchment areas. However, the Center of Excellence and the ART Plus centers are in the selected medical colleges. Those are the institutions which are more than 5 years of old, with a proven track record of skill training, academic excellence, and cutting edge research in the HIV sector. Now, the district level categorization throughout India has been divided into high, moderate, low, and very low, basing on the priority levels. Now, the high priority level has been assigned to those areas where the adult prevalence is more than 1%, or people living with HIV are more than 5,000 population. And in the moderate priority area, the adult prevalence is 0.4% to less than 1%, whereas the people living with HIV amount to 2,500 to less than 5,000. And the low priority zone is where the adult prevalence is 0.20% to less than equal to 0.40%, or people living with HIV amount to a size of 1,000 to less than 2,500. And very low priority are those adults prevalence is less than 0.20%, or people living with HIV amount to less than 1,000 population. Now, the integrated counseling and testing centers, they're basically of two types, that is fixed facility ISTC and mobile ICTC. The mobile ICTC are the temporary clinics, whereas the fixed IC facility ICTC are the standalone ICTC, which are at the district and at above levels they cater to a larger population. And the facility integrated ICTC, they are situated where there is less caseload and below the block level. Now, coming to surveillance, HIV sentinel surveillance is basically to determine the level and the trend of the HIV epidemic of HIV infection amongst the general population as well as in the high risk group, and also to understand the geographical spread of the HIV infection in order to identify the different new emerging pockets and to estimate the HIV prevalence and burden in the country. We have certain terminologies like migrants, that means the people moving from one place to another, irrespective of distance, time, and population occupation. Transport workers are the people who work in the transport industry. They have likelihood of exposure to HIV or STDs, like commercial truckers, commercial drivers, long distance truckers, motor vehicle, and population serving as mechanic, as helpers. The high risk groups are includes the female sex workers, the men having sex with men, IV drug users, the transgenders. The bridge population includes single male migrants, long distance truckers, and the general population includes pregnant female, which is taken as a proxy indicator. This sentinel surveillance is continues for about 3 months. It is a cross-sectional survey of high-risk group. The frequency is every 2 years. It is done between 15 to 49 years of age, and it is done by an unlinked anonymous testing by two-test protocol. The HIV serosurveillance includes the prevalence of HIV in the ANC females, which is taken as a proxy indicator for HIV prevalence in the country, and the prevalence of HIV in ANC females happens to be about 0.22%. And AIDS case surveillance, STD surveillance, behavioral surveillance, and integration with surveillance like other diseases like tuberculosis. The other strategies includes Suraksha Clinic for treatment of STD and RTI, then condom promotion and distribution by the health worker males and the frontline workers, safe blood practices in the institutions and in the blood banks, Red Ribbon Express between the different cities, specific integration for interventions for IDUs like distribution of clean needles and syringes, opioid substitution therapy, and link worker schemes. The newer schemes that has been introduced are Sampurna Suraksha Yojana. The aim is to cover at-risk HIV negative population through a cyclical, comprehensive package of services as per the need to keep them HIV free, thus increasing the country progress on prevention of new HIV infection. Now, who are the persons who are actually at risk? They are defined as any individual who are at risk of acquiring HIV or STD due to the risky behavior of self or their partners. And they are like, for example, self-initiated client at ICTC or DSRC, then social sexual network of self-initiated clients, a spouse of high-risk group, that is female sex workers, men having sex with men, the TGs, and needle syringe partners of IDUs or former IDUs, youth and adolescents who are at risk due to the risky behavior, and STI RTI client visiting the DSRC with STI complaint. Now, virtual intervention to reach out at risk population and key population. Then there is integration with NTP and National Viral Hepatitis Control Program. There is also community-led monitoring wherein community members, including people living with HIV, will themselves assess what is the quality of NACP and Prevention and Control of HIV/AIDS Act implementation at the peripheries to prevent discrimination and stigma. The goals and the objectives of NACP is that the basic objectives includes 95% of the people who are at risk of acquiring HIV infection using comprehensive prevention methods, and 95% of the HIV positive know their status, and out of those 95 people who know their status, they are on treatment, and 95% who are on treatment have suppressed viral load. Then 95% of the pregnant and breastfeeding women living with HIV have suppressed viral load towards attainment of elimination of vertical transmission of HIV. And it is seen that less than 10% of people living with HIV and key populations experience, however, stigma and discrimination. And there should be universal access to quality of STI and RTI services to at-risk and vulnerable population, and attainment of elimination of vertical transmission of syphilis. Now, what are the goals of NACP? NACP Phase 4 aims to reduce the new annual infections and AIDS related morbidities by 80% by the year 25-26, with the baseline value of 2010, and aims to attain dual elimination of vertical transmission, elimination of HIV AIDS related stigma, while at the same time promoting universal access to quality STI and RTI services to at-risk and vulnerable population. The goal one, that is to reduce annual infection rate of HIV infections by 80%, is to continue and evolve existing targeted interventions and link worker schemes, and also to accelerate reduction in the new annual HIV infections through a basket of strategies tailored to the high risk and at risk, and also to the low population risks. The goal two happens to reduce the AIDS related mortalities by 80%, develop and roll out tailored communication campaigns focusing on mainly risk perception and HIV counseling, testing, services uptake, augment to the existing HCTS models, and maintain existing care, support, treatment, CST services. Now, goal 3 will eliminate vertical transmission of HIV and syphilis. By this, it will augment the comprehensive synergy with NHM for testing of pregnant women for HIV and syphilis. They will introduce and scale up dual test kits for HIV and syphilis to fast track the progress in the dual elimination. Also, to strengthen the retention and on ART adherence amongst eligible women living with HIV/AIDS. Goal 4 is to promote universal access to quality STI/RTI services to at-risk and vulnerable population, and also to augment access to quality STI/RTI services. Strengthen the strategic information on STIs and augment the DSRCs. Goal 5 is to eliminate HIV/AIDS related stigma and discrimination, and it will actually, this phase 4 5 will build upon the game changer initiatives of NACP phase 4, which is an extension in order to accelerate the progress on elimination of HIV/AIDS related stigma and discrimination. By this, they will design and implement the different communication strategy and undertake sensitization on elimination of HIV/AIDS related stigma. Now, these are the sources which I have taken or referred to. So, in the end, I would like to conclude that NACP Phase 5 will take the national AIDS and STP response till the financial year 2025-26 towards the attainment of United Nations Sustainable Development Goals 3.3 of ending the HIV/AIDS epidemic as a public health threat by 2030 through a comprehensive package of prevention, detection, and treatment services. Thank you.